All right, Fahad, I think we should start at this point. It's 6 p.m. exactly, 5 p.m. exactly,
Yeah, we
and
are on time. So
we're on time at 11 a.m. EST.
yeah,
All
so
right,
thank
please
you
go ahead.
everybody for joining us. Um, my name is Fad Halebi. I'm the head of Sports Medicine Chapter and Saudi Orthopaedic Association. Actually, this is our first activity in this year. We start late, but this is our first activity. So our activity is going on this year. We have a lot of international webinars. We have some fellows around. We have some cadaver courses inside Saudi Arabia. It will be in around this year, and hopefully a lot of our colleagues will join us and will get benefit. And anyone has like an idea of our activity in sport medicine in Saudi Arabia or around the world, we are happy to share with you. And I encourage everyone to follow us in our Instagram to get update in our latest activity. Um, Today, we are glad to have Dr. David Wasserstein and Dr. Wolf Petersen and Dr. Hamza. He's one of our scientific committee. He will lead the discussion and will introduce our guests. Hamza, go ahead.
Thank you so much, Dr. Fahad Halebi. It's an honor and a pleasure to have two of our greatest speakers in the field in today's webinar. I'm very happy to be the moderator of such a session. For our first speaker, please allow me to introduce Professor Wolf Petersen. Professor Petersen is the chairman and the head of the department in Martin Luther Hospital in Berlin. He's a member of the board of the German Society of Joint Surgery and also a member of the board of the German Knee Society. With regards to his experience in osteotomy, he's published over 500 papers that has a way or another has relation to the osteotomy and the knee surgery field. Professor Petersen, please welcome to our webinar.
Yeah, thank you so much for this kind introduction and also for this kind invitation. And yeah, maybe it's time to come back again to Saudi Arabia. The last time I have been in Saudi Arabia was 2009, long time ago, but it's also a pleasure to do it online. Yeah, let's talk about osteotomies in ligament-deficient knees, and I will concentrate mainly on the sagittal plane. So if you have a mobile device, I have several QR codes in my presentation. So if you have another mobile device, you can scan these codes, and via these codes, you can get additional information such as open access papers or videos via my YouTube channel. Yeah, let's start with a very simple observation. A ball on the oblique plane rolls down. This is really a simple observation comparable to a skier who rides a slope. And the same is true for the femur, because the femur slides back relative to the tibia, and this can put stress on the ACL, especially if the tibial slope is increased. So we have a normal tibial slope, 3 to 12 degrees, and per definition, a tibial slope of more than 12 degrees is increased, and a tibial slope of less than 3 degrees is a decreased tibial slope, and decreased tibial slope can have can cause an increased load for the PCL. Some biomechanical studies. One of a friend of mine, Jens Agneskirchner, he published this 2004. he performed a cadaver experiment, and he found that an increase in slope resulted in significant anterior translation of the tibial plateau, which could be responsible for the increased stress in the ACL. But this study was mainly performed to demonstrate an effect of a slope increasing osteotomy to the PCL deficient knee. Another study by Florian Imhoff, published several years later, he investigated the influence of a slope decreasing osteotomy on ACL reconstruction, and he found that slope reducing osteotomy decreases ACL graft forces and anterior tibial translation. But the same is true for the tibial slope and stability of the posterior ligament deficient knee. Some biomechanical study, Giffen and co-workers from Pittsburgh, they showed that increasing tibial slope in the PCL deficient knee reduces the tibial sag by shifting the resting position of the tibia anteriorly. And Bernardson, he is from the group around Rob Laprat. He showed that PCL graft forces increased as tibial slope decreased in the loaded and unloaded states. So therefore, a decreased tibial slope of less than 3 degrees could be responsible for an increased load in the PCL. So in conclusion, the biomechanical data suggests that slope correction could or should play a role for the treatment of ligamentous instability. So how to measure tibial slope? There are several methods to measure it. You can take the anterior tibial cortex as reference line, the middle of the proximal tibia or the posterior tibial cortex, and the most accepted method is the mid axis of the proximal tibia. This method has been introduced by de Jour. But when you look on the middle X-ray, you can see here the slope as measured to the tangent of the medial tibial plateau is 10 degrees in this ACL revision case. But when you look to the right and see the whole tibial image, you see a so-called bowing tibia. And this is a good example to show why these short proximal tibial X-rays can underestimate the real tibial slope, because when you use the mechanical axis, trying to make an axis between the center of the ankle and the middle of the tangent to the tibial plateau, then the slope is definitely higher. Therefore, we recommend when you plan an osteotomy, or when you have the idea for an indication of an osteotomy, you should always do an X-ray of the complete lateral tibia. So, but we could not only look to the tibial slope, we should always also look to the coronal plane, because slope and coronal plane deformities are often combined. And when you look to the coronal plane, we differentiate 3 different types of deformity. Here on the left, the true osseous varus deformity, characterized by a decreased MPTA. Then we have the articular varus deformity, mainly characterized by cartilage damage in the medial compartment. And then the so-called ligamentous varus deformity, which is caused by lateral ligamentous laxity. And it is radiological, characterized by an increased joint line conversion angle. So for ligamentous instability, the last type of varus deformity is important, because you can understand that when you have this kind of lateral opening, that means that you get stress on the lateral collateral ligament and also on the ACL. Example, this is my first case. I will show you 5 cases in my presentation, and each case is an example for a special situation. So this is a patient with failed ACL reconstruction, 33 years. He has an varus deformity of 6 degrees, decreased MPTA, but increased joint length conversion angle, but also an increased tibial slope. Now there's a question, what would you do? How would you correct this varus deformity in combination with the tibial slope? Would you do a medial open wedge osteotomy or a lateral closing wedge osteotomy? Yeah, this is the answer. I would do it. The problem with the medial open wedge osteotomy is that the medial open wedge osteotomy tends to increase the tibial slope, because and the course is here or this schematic drawing shows the cause for this tendency to increase the tibial slope, because in most of our osteotomies, the hinge zone is in the posterior lateral aspect of the proximal tibia, and if the hinge is in the posterior, or if we have a posterolateral hinge, then the osteotomy has a tendency to increase the tibial slope. Therefore, it is important to rotate the hinge to the anteromedial aspect, and you can do this with help of a hinge wire and also with use of a sigil to perform a so-called cold osteotomy with a sigil. We recently published this technique in arthroscopy technique. Then it is important that the hinge is above the fibula, and I also recommend to remove a little wedge, a little anterior wedge, that makes the rotation of the proximal fragment easier. And then we always use shunt screws. You can use these shunt screws as a joystick to correct the tibial slope. And these 4 modifications are pretty good steps to or technical tips and tricks to decrease the tibial slope in those combined deformities of varus and slope, tibial varus and increased tibial slope. So next case, also a case after ACL reconstruction, failed ACL reconstruction. This is a 29 years old male patient, but he has no varus deformity. He has a slight valgus deformity. And yeah, now the question is, again, what would you do? I think it is clear. Yeah, we should look for an osteotomy or recommend an osteotomy to the patient. We always do this with a shared decision-making process. And yeah, the rationale for this recommendation is this landmark paper by Webb. It's an Australian group, and they compared several groups of patients with a PTS, or posterior tibial slope, of less than 6 degrees, tibial slope of 6 to 12 degrees, and tibial slope of more than 12 degrees. And he found that 59% of patients in the group with a tibial slope of more than 12 degrees had a failure of the primary ACL reconstruction. And that's why this 12 degrees of tibial slope are today a well accepted threshold to perform an osteotomy in an ACL revision case. Several authors or several surgeons have or tried to perform a risk stratification. One is Philipp Schuster here from Germany. He identified many risk factors, for example, high-grade instability or associated meniscus ramp lesions, the type of injury, trauma mechanism, number of previous ACL reconstructions, previous LET, age, sex, etc., or family history. This is also important, or ACL injury of the contralateral side. And then he is a enthusiastic skier, and that's why he called his risk stratification concept the avalanche concept, because the avalanche risk is also given by the slope of the mountain or the hill and associated risk, the presence of associated risk factors. And so he had these according to this example, he designed these two maps, one for revision ACL and one for primary ACL. And depending on the slope and the presence of associated risk factors, you can calculate the individual risk for the patient, and that could be a help to perform a risk stratification before surgery, and maybe give the patient a better recommendation. When you have when you made the indication for revision, for example, in this case with the tibial slope of 14 degrees, this was a 21 years old male. Then the next question is, how would you do the osteotomy? You can do it in 3 different ways: supratubercle, retrotubercle. With the retrotubercle osteotomy, you have to remove the tubercle, and also infratubercle. I give you my answer. I would perform an intratubercle osteotomy, and you can see it, the reason for my decision on the next slide. Because the disadvantages of the supratubercle osteotomy is the risk of a patella infera. You have only a very short proximal fragment, and that's why the osteosynthesis is quite difficult. The retrotubercle osteotomy is technically demanding because you have to detach the tibial tubercle. That's why this is also not my favorite technique, and I told you my favorite technique is this infratubercle technique. We described this in 2017, because in my hands it has no real disadvantages. Osteosynthesis is pretty easy, and also the execution of the osteotomy is also pretty easy. You can do it in combination with the ACL reconstruction, but also, and in most of the cases, I perform it in combination with the tunnel filling. Here you can see some schematic drawings. We start with introducing 2 guide wires below the patella tendon. You have to insert 2 Homan retractors, but it is very important you cannot protect the posterior vessels with the Homan retractors. This is not possible. You have to be very careful that you leave the posterior hinge intact. Then osteotomy along the wires and wedge removal, then closing of the osteotomy, and finally the osteosynthesis. If you are interested in this osteotomy, you can scan this code, and this code will guide you directly to the website of the arthroscopy technique journal, and you have access to the article and also to the video. Here you can see the result, the reduction in posterior tibial slope to 8 degree, and yeah, for me this 8 degree is a good result. These are the results of an systematic review. They scanned all studies describing clinical outcomes after proximal tibial closing wedge osteotomy for slope correction, and in all these studies, posterior tibial slope was less than 10 degrees. So our aim should be definitely less than 10 degrees, and optimal is in between 5 and 7 degree. This is the outcome of this consensus paper published by Wackerle and the posterior tibial slope consensus group. You can plan your slope correction according to this method showing here on the X-ray, and by calculating the amount of or the degree of slope correction, you can also calculate the size of the height of the tibial wedge, which you have to remove. But there's one point: you cannot always correct the full tibial slope, because in cases even with slight hyperextension, you can produce severe hyperextension with this anterior closing wedge osteotomies. That's why in some cases the amount of slope correction can be limited, in my opinion, and therefore hyperextension is for me a contraindication for tibial slope correction. Okay, let's move to case 3. Case 31 years, chronic posterolateral instability after a motorcycle accident with a tibia fracture. Here we can see the nail on the right side. The MPTA is a post-traumatic varus situation. The MPTA is 83, 7 degrees varus, and on the lateral side he has only 2 degrees varus, and he has or he had a very low tibial slope of 1 degree. So again, my question is, and the joint line conversion angle was also slightly increased. That's why I decided to perform before I go for a PCL and posterolateral reconstruction. I decided to perform an osteotomy. First, we removed the nail, and then I performed an osteotomy. And now my question is, how would you do this? This answer is wrong. So the mark should be here. So because this is the ideal indication for a medial open wedge osteotomy, because as I told you before, the medial open wedge osteotomy has a tendency to increase the tibial slope. You can insert your spreader maybe in the anterior aspect, but this is mostly not needed. So you can perform the osteotomy in the normal way, and in most of the cases you will get an increase of the tibial slope. The only thing I would recommend to insert 2 stable guide wires or even shunt screws to see the amount of slope correction with this osteotomy. And here you can see an almost neutral or slightly overcorrected mechanical axis of the tibia and tibial slope of 11 degrees. Case 4 was a 23 years old female patient with recurrent posterior instability after ACL, PCL, and PLC, or posterolateral reconstruction. She had a posterior tibial slope of 0.8 degrees. You can see here remarkable tunnel widening and a slight varus deformity, 1 degree varus. So, and in this case, I decided to go for an infratubercle anterior open wedge osteotomy. The technique is pretty much the same as the anterior closing wedge osteotomy. But after performing the osteotomy, you spread the gap, and then you can insert a spacer or your spreader to contain the amount of correction, and then you stabilize your osteotomy with an appropriate angle or locking plate. Here are the fluoroscopic images of the surgery. In this case, we combined the osteotomy with the filling of the enlarged bone tunnels, which you can see here in the superior row, and in the inferior row here you can see the osteotomy guide wires directly below the patellar tendon. The hinge is at the insertion of the tibial insertion of the posterior cruciate ligament. Then here spreading of the osteotomy and stabilization or orthosynthesis with a locking plate. Next case, he or she, also a female patient, 39 years. She had a trauma in adolescence and came with a chronic posterior instability. Posterior drawer was double plus, but no posterior lateral instability or posterior medial instability. And yeah, the MRI showed posterior cruciate ligament injury, kind of elongation, which is typical for these chronic PCL cases. Yeah, so what would you do in this case? Further diagnostic is always right. Yeah, we performed also stress X-rays, but when I saw the stress X-rays, first I noticed the posterior tibial translation in this case, but when I had a closer look to this image, I also saw that the slope was not normal, and that's why we did also a long on X-ray of the whole lateral tibia. And here you can see a real severe negative tibial slope of minus 9 degrees. So the trauma in the childhood or adolescence was definitely not a PCL injury. It was more an injury of the anterior epiphysis of the tibia, which resulted in genu recurvatum, and in the long term of a chronic injuries or chronic stretching or elongation of the PCL. So that's why my question, which therapy in this case, PCL reconstruction, infratubercle, anterior open wedge osteotomy, or the intra or retrotubercle anterior open wedge osteotomy with detachment of the tubercle. In this case, I decided for a retrotubercle osteotomy because this is just my experience. Because in these cases with a negative tibial slope, when you perform an osteotomy, an infratubercle osteotomy, you produce a very prominent anterior spur. That's why when I have a tibial slope of less than 0 degrees, I always go for an retrotubercle osteotomy with detachment of the tubercle. As you can see it here in this schematic drawing, here you can see the detachment, then the oblique osteotomy. This is pretty much the same. Then the direction of the osteotomy is pretty much the same as for the infratubercle osteotomy. But then you open it, and then you can detach the tibia, the tubercle again with two cortical screws. Some French guys just use this type of osteosynthesis as a type of so-called bioplating. I always perform an additional osteosynthesis with a locking plate from the medial side. Here you can see the fluoroscopic images here, the detachment of the tibial tuberosity and the guide wire in plate. Aim is the inferior part of the posterior of the PCL insertion at the tibia. And then you can see here the osteotomy along the guide wires. Here you have to make sure that you do not penetrate the posterior tibial cortex, that you should leave the posterior cortex intact. Here you can see the spreading with the slope correction already. Here is the negative slope. Here you can see a slightly positive tibial slope. Then here's a bioplating. Then I always fill the gap with allergenic bone chips because the gap is pretty large in these cases. And then I combine the so-called bioplating also with a metal osteosynthesis with a locking plate from the medial side, as you can see it here. Here you can see the result, negative slope after this injury of the anterior growth plate here. And yeah, here you can see increased slope with a physiological almost physiological slope in this case of approximately 3 degrees. So in conclusion, I will do my conclusion I will divide my conclusion in two algorithms, one for anterior instability. So when I have the or indication criteria for an osteotomy for me is the recurrent instability after ACL reconstruction and the primary instability in combination with other risk factors. And when I have a posterior tibial slope of more than 12 degrees in combination with the varus deformity of less than 5 degrees or a valgus knee or neutral knee, then I would perform an infratubercle anterior closed wedge osteotomy. Other indication criteria for osteotomy in the frontal plane are chronic anterior instability and also medial osteoarthritis or medial cartilage damage. And in these cases, when I have a varus of more than 5 degrees and a joint line conversion angle of more than 2 degrees in combination with the posterior tibial slope, I recommend to perform this modified medial open wedge osteotomy. And on the other side, if I have a posterior tibial slope of less than 3 degrees and a varus deformity and a joint line conversion angle and increased joint line conversion angle in combination with posterior instability, then I would go for a conventional medial open wedge osteotomy. Here you can see the situation for a posterior cruciate ligament injury or posterior instability. Indication criteria for osteotomy in the sagittal plane are also recurrent posterior instability after PCL reconstruction or primary chronic posterior instability in older patients sometimes, or the post-traumatic general recurvatum. And when you have a posterior tibial slope of less than 0 degree, then I would go for an anterior closed wedge osteotomy, HTO with tubercle detachment. But when you have a posterior tibial slope of in between 3 and 0 degrees, then you can go for the quite easier infratubercle anterior open wedge osteotomy. And other indication criteria for the case of posterior instability are, of course, posterolateral instability with the combination of various deformity in the frontal plane, and also in combination with the joint line conversion angle. And in these cases, you can achieve a slope correction very easily, even with a conventional medial open wedge osteotomy, because this osteotomy has a tendency to increase the tibial slope. Yes. And finally, I would like to invite you all to a meeting I'm organizing with 2 or 3 friends of mine, the International Knee Days. It's a meeting which will take place next April in Berlin, and also it's a pleasure for me to announce this diploma in knee surgery, which is also an initiative of this International Knee Academy. Thanks for your audience.
Thank you so much, Professor Petersen, for this very informative talk. And thanks for the invitation to the meeting. And no one has an excuse. It's a year ahead notification. So you guys should all try to sign up for this as soon as possible. We have 2 questions already written. And if someone else wants to also actually ask the question himself, you can also go ahead. I'll read the first question from Muhammad. His question was with regards to the avalanche concept. Is there an acceptable tibial slope for primary ACL? Should we aim for less than 10 degrees of tibial slope, or just reserve osteotomies for revision cases? What's your take on this, Professor Petersen?
I think for primary ACL, the indication is not as established as for the revision cases. For the revision cases, I think it's well accepted that if we have a posterior tibial slope of more than 12 degrees, yeah, we should think about it and we should discuss it with our patient. And if the patient agrees, yeah, then we should go for a slope osteotomy. That's how I manage it with the patient. And in the primary patient, we have to be definitely more careful. For me, an example would be maybe a patient with a tibial slope of 17 or 18 degrees, maybe with a contralateral ACL reconstruction, or other severe associated risk factors. But I think 10 degrees is definitely would be definitely no indication for me to perform an osteotomy in a primary. Even in a revision case, 10 degrees would not be my threshold to perform the osteotomy.
So just to recap on the answer, 10 is still within the normal limits. So it is acceptable and it's actually normal. So unless it's a failed in revision, I think that's what Professor Petersen is trying to say. You definitely are not going to use a 10 as a reference point. For primary, I think Professor Petersen was mentioning that, yes, if it's above limits. But if it's still within the 7 to 12, unlikely unless there's, I think, associated pathologies. Agree with that, Professor Petersen?
Yes.
Okay. Dr. Wasserstein, you have a take on this as well for primary ACLs?
Sure, yeah, it's a great question. I agree that there's no clear defined research. I kind of look at the overall picture, like an ACL is not necessarily an ACL. So if they're chronic and they have a high slope, and they've got secondary signs on their imaging, like some static anterior tibial translation, never had an ACL done before, if they've got a macerated medial posterior horn meniscus, then I'll start thinking about offering them slope correction first. It can be a little bit of a harder sell to a patient though, because they're just coming thinking they need an ACL. But if they come and they have a anatomically and structurally normal knee with a higher slope and no secondary changes, then I'll usually just go to primary ACL reconstruction and talk to them about that's a higher risk factor for failure. But if they have these secondary changes, I'll definitely start um, suggesting to them that we should correct their slope.
Okay. I think I pretty much do the same. Very, very unlikely I would do in a primary case and a slope correction or an HTO unless it's really very high numbers and associated pathologies. Professor Petersen also mentioned look at the contralateral knee because that is an indicator if this patient has been through a failure or lacks the graft because of these numbers. And I personally have done actually a case just 6 months ago of a guy that had 2 revisions in a contralateral knee. And I did a slope correction and a BTB graft. It's more commonly that we do hamstrings here. So I did a BTB graft and a slope correction in the case due to this scenario that Professor Petersen mentioned, which is the contralateral knee. He had 2 revision ACLs and he still actually had a failure and a valgus knee. So we started with the one that's more acute, and then we're actually going back to the contralateral knee after. I will now ask the second question that we have, and then I'll open the mic for Ahmed Alim. Khalid Al-Hammam, I actually think associated injuries because, so I think you had your question answered, Khalid. Ahmed, can you, Dr. Fahad, please unmute Ahmed Alim?
Dr. Ahmed, can you hear us here?
Yes.
Yeah, we can.
Yes, hello.
Yeah, we can hear you.
Yes. Okay. So thank you, Professor Petersen, for the wonderful and informative talk. Such a great pleasure. So I have like a technical question regarding the situation of a double varus osteotomy. So as we know from the geometrical biomechanical studies by Dr. Noyce, so when doing a medial opening wedge osteotomy with the posterolateral hinge, usually there's a tendency to increase the slope. But if we maintain the posterior gap, almost double that of the anterior gap, the slope will be almost maintained. So my question is, in a scenario where I change the hinge location, whether it's lateral or anterolateral, is there like a ratio between the posterior and the anterior gap to measure how much of a slope correction I can make?
No.
Okay.
I maybe I can't give you an answer. Maybe you can calculate the amount of slope. It should be possible, but in my clinical practice, it plays no role. I control the amount of slope correction in the fluoroscope.
Okay, just if I can just continue on the question. So if I may be more specific, so in your technique, Professor Petersen, you take like an anterior wedge from the biplanar osteotomy.
Yes.
With like the size of the wedge, is it dependent on the slope correction you want to do, or is it always consistent?
It's always 3 millimeters or 5 millimeters. It's so small. It's very hard. Yeah, it should be just a small wedge. 3 millimeters is enough.
I
Okay.
think Wasserstein has a comment on that. We work in a project, difference between posterior slope and anterior slope in the same tibial cystomy. And I think you published a paper a couple months back. right?
No, we haven't published that one yet. We have about 30 cases now, and don't worry, we'll send you a copy of the preprints. It looks to be a pretty good linear relationship if you do an anterolateral hinge, that you get roughly 2 to 1. So you can get a degree of increase by doubling the back to the front, roughly. So we'll publish that hopefully relatively soon. One of my residents is working on it. It's not a perfect relationship, though. It's not like a very, it's actually a reasonable correlation. Our squared was better than I thought it would be. And it does look linear based on the corrections that we did. But I've never been able to get more than around 6 or 7 degrees of slope correction with the anterolateral hinge, just to give you an idea. And then the one time that I tried, ended up with a hinge fracture, so that wasn't fun. But that case is in there as well. So there's roughly 30 of them, and it's about a linear relationship, maybe 2 to 1 roughly.
Last question, I promise. So, would any of the panel consider doing a lateral closing wedge to address the slope, or is it always a medial opening wedge is the go-to technique?
Now, let me start. I always do a medial open wedge osteotomy. I know that some colleagues perform also lateral closing wedge, but in my opinion, it's technically too demanding to remove a lateral two-dimensional or three-dimensional wedge to correct the varus and the slope. That's why I prefer the medial open wedge technique.
Great.
Same for me. I would say that I did more in the beginning because I was sort of mentored by somebody who did almost exclusively lateral closing wedge. And now it's basically for post-traumatic deformities where you think that there's sort of lateral collapse from like a tibial plateau fracture or a anterolateral hyperextension impaction fracture.
Thank you.
Okay, so if you haven't noticed, Ahmed is actually one of our fellows, and he's a pain in the neck, and I'm very happy that he got to ask all the questions right now, so I don't have to deal with that tomorrow. Thank you, Ahmed. Go on mute, please. All right. Just the last question from Dr. Yagoub. Is there a difference between medial tibial plateau and lateral plateau slope? And which one do you measure usually? Professor Petersen, Dr. Wasserstein.
Yeah, I usually measure the medial tibial slope because per definition, tibial slope is measured by the medial tibial plateau. But of course, in some cases there is a difference. Mostly the lateral tibial slope is always a little bit steeper than the medial tibial slope, but the lateral tibial slope is, in my opinion, not very reliable to measure.
Because of its convexity, I guess.
Yes.
Exactly. Okay. The next question and the last one.
And this is maybe also a disadvantage of the medial open wedge osteotomy, because I think with this medial open wedge osteotomy, you influence the medial slope more than the lateral tibial slope.
Just to pick up on that point, I've thought about this a lot as well. And it may not actually be a bad thing because we're usually doing osteotomy in a chronic setting. And so most of the later literature on chronic ACL pathology shows that acutely there's anterolateral translation, but then chronically there's more medial translation, so posteromedial translation. And so I think that if you're doing it in a chronic setting, it's probably better to save the knee by reducing the strain on the posterior horn and the medial meniscus and maybe reducing that long-term posteromedial wear that the arthroplasty surgeons see in chronic ACL insufficiency.
Yeah, definitely. I totally agree. Yeah.
So it's a very good point, Dr. Wasserstein. Faisal, your question might be answered in the next talk. So we will proceed and start the next talk. We took a bit longer, but I'm very happy to hear all these questions. That just tells me how relevant and commonly discussed these topics are. Our next speaker is Dr. Wasserstein. Dr. Wasserstein is actually a graduate of University of Toronto residency and a Vanderbilt fellowship in the United States. He's a member of the knee dislocation study group, and he's also in the research in osteochondritis dissecans of the knee. He is my mentor, and I'm very happy to get to reconnect in this webinar and hopefully in person very soon with Professor Petersen. Thank you all, and please proceed to Dr. Wasserstein.
Can you share your screen, Dr. Wasserstein?
All right, can everybody see? We're good?
Yes, we are good. You can see your screen.
All right, thanks very much. I really appreciate this invitation and have a connection, obviously, to Fahad and Hamza personally and academically. And so it's a real pleasure to be invited and share some thoughts on this topic of the coronal plane in ligament deficiency of the sides. Obviously, osteotomy has seen a bit of a resurgence, lately, and I work at a center in Toronto where we do quite a lot of osteotomy for various reasons. My practice maybe a bit more for instability, but also a bit for OA. No real consulting disclosures. We have some fellowship support, nothing really going to be referenced in this talk. A shout out to Dr. Schatzker, as I'm one of the heads of his Joint Preservation Initiative, which is sort of his retirement legacy. I think everybody knows who he is. I'm excited today for this talk because it's fun to speak to an experienced audience of surgeons. I give a lot of talk to non-surgeons and residents or med students. So it's exciting to be able to talk shop with our lingo. I'm going to do a bit of a review of the biomechanics and the clinical data in this area, and then segue that into some clinical cases and sort of my approaches and some general tips for you to ponder and think about. There's not a lot of biomechanical data. There are a few key papers, I think, my opinion of key papers. There's, I'm sure, some that are important that I'm missing as well, but I thought I would talk about three of them. Two of them came out in the last few years, actually, which is very interesting. This is from a German group. They looked at a native knee and they looked at the strain threshold on the collateral ligaments and various amounts of varus and valgus. And so this sort of line that you see kind of over here is a threshold of a 4% ligament strain, which is associated with structural integrity loss. So that's why they chose that. And then they're looking basically to see where does the strain in the lateral collateral ligament or the MCL begin to approach that 4% threshold. And they showed that it's a 4-degree varus knee and a roughly 5-degree valgus knee for the superficial MCL, which I think is, really interesting numbers. These are tested for those who don't do biomechanical research or are that familiar with it, usually with standard standing loads. So if you weigh, roughly 80 kilos, then you put about 400 newtons when you're standing through each side of the knee. So that's how they load them. There was some differences to note on the MCL in various positions in terms of sort of what degree of valgus affected the anterior, middle, and posterior fibers more, versus obviously the LCL is a very small ligament, which you'll hear me refer to that a couple of times in this talk. I think it's our nemesis. Just one point about this, actually, they're measuring mechanical tibiofemoral angle, so that should be 0. How about in the setting of MCL reconstruction? These authors did a single bundle MCL, which you can see in the upper corner over here. And then they used an external fixator to create a distal femoral osteotomy with increasing valgus to look at strain in the MCL reconstruction, the superficial single bundle. And at 5 degrees valgus, again, starting to show a significant increase in strain. This is one of the original papers from Laprode's work back when he was in the mountains. They looked at knee flexion angle, and they looked at external rotation in PLC deficient state. So this is they define the posterolateral structures as the LCL, the popliteofibular ligament, and the popliteus. And what you can see here is the amount of external rotation based on the neutral alignment of the specimen, and then when they did a slope neutral and valgus producing medial opening wedge high tibial osteotomy. So this is the amount of external rotation they measure. They did section the posterolateral structures. It increased by roughly 5 to 6 degrees. And then just doing the osteotomy almost normalized it. It's a little bit higher and it's within the error bars, so it's not statistically significantly different. It clearly didn't fully normalize it. Maybe a little bit underpowered to show such small differences. But I think it's an important point. If you have chronic posterolateral corner with external rotation, I picked only their external rotation element. They also looked at strain and a few other outcomes. It's a pretty good paper to think about. Just doing a valgus producing osteotomy reduced some of that functional external rotation, which is interesting finding. There are other biomechanical studies, but just for time, I picked three that I thought were more important or most important to give us our ideas in thinking about how we approach patients clinically. And unfortunately, the clinical study data is even less. It's mostly small case series. Most people know that Frank Noyes published sort of the first one on this years ago, although there's some other publications on osteotomy, including from John Cameron, who I took over his practice back in the 90s. Anyway, so Naughty in 2014, they did HTO in PLC and mostly PCL. More than half were PCL deficient with hyperextension. I think it was about 17 patients case series, and it's a typical case series. Most of them did good to excellent results. Same with these authors, Arthur 2007. They also did HTO, valgus producing for and Varus, and they showed good to excellent results. Noyes' original paper, I think the big thing to look at that is, Noyes published on 30 failures of posterolateral corners, and about 2 in 5 of them had Varus, which was the largest predictive factor. So this was sort of one of the first sort of clinical papers to make us clue into the importance of the coronal plane in the posterolateral corner. And then this paper from 2007, I believe, is actually Laprod's group, 21 chronic PLC injuries, also treated with HTO. And again, a recurrent theme, like the people that are having trouble with this that you're treating are very rarely just deficient of, let's say, the posterolateral corner only. 2/3 of these patients had either a KD2 or a KD3L, so ACL, PCL, or one cruciate. And again, about 40%, so 2 in 5, reporting stability, not needing a second surgery after just HTO alone. And so I think that's, a good piece of information, because that should be in your toolbox, even as a standalone treatment sometime in the correct patient. And then the remainder did undergo ligament reconstruction. They waited a minimum of 7 months. And sometimes in that series, I think it was even up to 2 or 3 years later to do ligament reconstruction surgery. And people always ask about like what timing should you do and when do you decide to do the second stage? And the answer is, figure it out with your patient. Like your osteotomy needs to be healed. I'm not in a huge rush after the osteotomy heals. Sometimes the patients are, sometimes they aren't. I think if they're sporty and they're going to try to go back to sports, then you're going to do it a little bit sooner. If they're having trouble rehabbing, I really make them rehab well, at least get back to the muscle and strength that they had pre-op before the osteotomy, if not better, before saying, okay, we should, go back and do another big surgery, because the process of 2 surgeries for your patients is going to be, 2 to 3 years recovery, right, to get through all that. What have we learned from systematic reviews? To be honest, not a lot. There was a good review on MCL repairs and reconstructions in 2023, which looked at 18 studies. And it's interesting because the authors always mention in the discussion alignment, but none of the reported studies in that review actually really talked much about it. And they didn't have any summary data for us, just to say that, alignment is important. And if it fails, maybe do an osteotomy. Ned Amendola was at Duke now, a former Canadian. Was also did a review in 2011 did on chronic PCL and PLC injuries. It was more of a narrative review. And again, not a lot of data. They just reviewed the case series that I've already showed you. And they concluded that if you have this chronic PCL and PLC injuries with varus, that you should do a medial opening wedge HTO, and you should increase the tibial slopes. I'll always kind of joke with the fellows as if you're doing a medial opening wedge HTO for arthritis, you want to do it properly and be cognizant of not increasing the slope. And then in this setting, we purposely do it poorly to increase the slopes. We used to see a lot of the original, opening wedge medial osteotomies. They weren't quite aware of the slope issues, or at least some of the ones that I've seen in follow-up and whatnot. And so a lot of them had an unintended increased slope, but you would intend to do that here. There was an ISACOS consensus statement on chronic lateral injuries, which tell us, I think this is important. They didn't mention alignment at all in this statement that I could find. But 24% of anatomic reconstructions and more than 30% of non-anatomic reconstructions can fail depending on the case series. And I think this is, a really important factor. The lateral side is a difficult side. The LCL is small. It's a 4 to 5 millimeter ligament. The MCL is large. And a lot of athletes and stuff like that will have a varus alignment. So you will encounter this lateral side problem more often, and your primary reconstructions going to fail more often on the lateral side. So a lot of the surgery that we end up doing for this is lateral based. And then the rest is just published opinions, like a bunch of single author review papers that seem to just kind of reference each other with no clinical data. So that's perfect for me in this talk, because then I can just move right on to my level 5 evidence and tell you what I like to do. And if you come and work with me or observe or whatever, my clinic, everybody gets this X-ray. If they're a kid, they'll get an EOS 3-foot standing. If they're an adult, they'll get a regular. We do an OA workup for the adults for sure. That's going to change your algorithm. Do they have arthritic change? You're going to think about ligaments, but you can't forget about the arthritic change and the intra-articular component. Dr. Petersen did a beautiful job explaining what can happen intra-articularly, so you can get an intra-articular deformity because of ligament laxity, and you can get it because of arthritis. So you need a PA flexion view. You want to check the patella on a lateral and a skyline. So everybody gets this. And we routinely look at the joint angles, and although our radiologists will report them, we usually do our own assessment and check the mechanical axis deviation essentially in every patient and establish if there's a deformity, and then define the location of the deformity. And then if they're coming because of complex problems, if they have an old MRI, I might repeat it. If it's a bony problem, then usually CT scan relatively liberally for things like fibular head non-unions or malunions. How do you decide if something is acute and chronic? So we talked a lot about, okay, if they're chronic, more likely we're going to think about a malalignment and osteotomy. Well, how do we make that differentiation? And the answer is nobody knows. This sort of time-based orthopedic aliquot of 6 weeks or maybe 2 months has persisted throughout orthopedics, and I don't really totally understand why, but some people will use time, and it can be around that 2 month mark. My quick and easy of this is if you can do a dynamic walking assessment of this patient, meaning you can watch them walk and see if they have a varus or valgus thrust, and they can stand and do a 3-foot standing X-ray, then they are chronic. That means they're past sort of that acute phase, or at least subacute, if not chronic. And so that's when you should, start thinking about whether or not you really strongly need to do bony correction. These are things that kind of push me personally more likely to do an osteotomy or less likely to do one. So if they have a large deformity, I don't quite specifically use exactly these biomechanical literature cutoffs. I mean, the last 2 studies were from 2024 and 2025. So there was a time where we were using our Gestalt before that, and there wasn't even a lot of biomechanical data of what amount of varus or valgus significantly increases the strain of the contralateral ligament. If they're chronic, for sure. If they're multi-ligament, which most of them are, and they have deformity, remember that if you have varus or valgus, that changes the strain on your cruciates. So it's not just about the collaterals, but they all work together. And then you can think about doing things to combine slope correction, as Dr. Petersen has expertly pointed out. So you can really dial things in biomechanically. And if they do have a combination injury, I'm more likely to do a stage with an osteotomy. There's a bit of a dichotomy of patients in my mind. You have patients on the one hand, which are maybe pretty low level or low activity level, and they can be treated, with osteotomy alone. And that 2007 Laprade paper, I think, showed that about almost 40%. And I think that pretty much mirrors what I see in practice. You can get improvements in their walking. You can unload their overloaded side. And if they're relatively low demand, it'd be enough for a lot of patients. And then you have this other group, which is quite a bit more high demand. Unfortunately, a lot of them have unrealistic expectations. This it's not impossible to get back to high level sports or heavy manual labor after having an injury like this, but it's certainly less likely. But nonetheless, you know that these patients are going to try to push this and stress this. And so for me, I'm thinking if I did just a reconstruction of ligaments alone, that's going to be a recipe for a higher failure rate. So I will recommend a staged reconstruction. If their BMI is elevated, I actually pushed me to do an osteotomy and maybe not even grafting, kind of in that low activity level patient. And then you're thinking more about closing wedge osteotomies with modern implants. So one of the nice things about modern implants for osteotomy is we're a little bit less scared of high BMI patients than we were previously, concerns for non-union and things like that. And then obviously the lateral side, aggressively osteotomizing more so on the lateral side than medial side problems. And so that just kind of fits with the less likely is pretty much the opposite. When you're doing osteotomies, I prefer biplanar step cuts. These allow you to control rotation, dial in corrections. And then, if high BMI or you're doing a ligament reconstruction at the same time, I would prefer to probably do a closing wedge. Not always, it's just a preference. And then, if you're going to operate on the same bone, I prefer to stage it. So you could do a distal femoral osteotomy and lateral ligament reconstruction. If you did the femoral osteotomy on the medial side or even on the lateral side, it's a different bone. But if your apex of your osteotomy is going to be in the same side, you're trying to run tunnels and stuff like that, that's a big danger zone for me. I obviously would want that to be healed. I wouldn't want to have a risk of a hinge fracture I don't see, and then I get poor fixation on grafts and et cetera, et cetera. So let's go through some cases. Case one is a chronic lateral side. It's a nice guy. He's 33. He fell off the ladder about 5 months ago. He comes in with a crutch and a brace, and he's seen two orthopedic surgeons. He was treated non-operatively for this injury. His examination, he's in varus bilaterally. He's got a thrust. He uses his brace. He's got hyperextension. And then here's his pictures and his examination. So you can see this. This is a concerning clinical examination right here. This is a full extension, significant opening. So he's got obviously significant lateral side instability. He's got a posterolateral drawer and a significant dial with ear recurvatum. And he has a significant anterior drawer as well. Here is the imaging for him, and I kind of blew up this little piece here so you can see that his original injury likely involved some sort of tibial capsular avulsion fracture and fibular head fracture, which is now sort of healed or partially healed as a non-union or a malunion. And that will make you think about what your options are for running grafts through a fibular head. Here's his standing alignment. He's got a significant mechanical axis deviation. We've known for a long time to look at those contributing factors to why he might have varus. So is it from his femur? The answer is yes, 95-degree lateral distal femoral angle. Is it from his tibia? Answer is no. He's got a normal tibia. And then is it from his joint? And the answer is yes. And he's got an interesting problem. He's got both an extrusion of his meniscus, from a root tear at the back on the medial side, and he's got obviously intra-articular deformity because of significant lateral laxity. And so you look at it from the front, it's okay, this is complicated, but not terrible. And then you look at his x-ray on the lateral, and he also happens to have a 20-degree slope with anterior tibial translation. So a lot of things going on with this guy. Oh, here, I'll go back one. I didn't review the rest of these. Here's his anterior tibial translation. This is his, I don't know if you can see. Oops. Did that go down?
We still can see.
We can see everything. It's working.
I can't. How do I get that back?
You mean your presentation? You shared your screen, it's not showing anymore? Okay.
Yeah, it's not showing it to me anymore.
Can you stop sharing and reshare it again? Try.
Sorry about that. Apparently my first time on Zoom. Back, we're good? Great. I won't do that again. All right, so this is his arthroscopic view. I'm a leg holder, scope surgeon, so this is the leg hanging at 90 degrees, and you should not be able to see the posterior horn root in that setting. Here he is in some varus. So he's got most of his opening, consistent with that tibial sided capsular avulsion and fibular head. So a lot of his opening, obviously submeniscal. And so osteotomy is useful here. We got multiple problems. We have an ACL deficient, high tibial slope, and static anterior tibial translation. We have LCL PLC deficiency with femoral varus. We have a medial root tear, and we have this fibular head malunion. So 100%, this is not doable in one surgery in my hands. I don't know how long it would take to try to fix everything, and it would be pretty difficult. There's some questions about his meniscus. Will the root heal? It's 5 months out. It's 33. At least he doesn't smoke. With the fibular malunion, do I need to do anything about that? And to be honest, in this case, I actually kind of played an ostrich and stuck my head in the sand on that part of it and moved on. But it was definitely in the back of my mind. He wants to be a roofer again, and the chances of that I think are going to be pretty low. So you have to manage expectations of your patients. You have to think about things like leg length. Am I going to overcorrect or undercorrect? One of the things that Professor Petersen mentioned is preference to go subtubercle, which is mine as well. You also, going subtubercle, get a bit of an cortical overlap, and I think it's a little bit more difficult to get high corrections. So I know he goes retrotubercle for negative slope. I will go retrotubercle for very high slope reductions. So I'll go subtubercle for anywhere sort of 16, 18. And then once you get past that, I usually go retrotubercle, and then you can put the tubercle in the right spot. I think you probably get a little bit less recurvatum as well. So what did I choose for him? I did a double closing wedge, an anterior closing wedge, high tibial osteotomy, a DFO, and repaired his root. And then we came back, took everything out, and did his ligaments. And so here's his post-ops, and we tried to sort of just drill this a little bit. I was able to put a graft into it eventually, but it certainly was a bit of a concern. And then here's his post-op alignment in the coronal plane. So got him down to about 6 degrees. Retro tubercle got him to relatively neutral, taking a tiny bit off the medial side and then normalizing his femur. Second case, chronic medial side. Also another laborer, 42 years old, says he's a former smoker. Construction workers in Canada are all pretty much similar. They're all about 10 of them stand around a pothole smoking cigarettes and drinking Tim Hortons and watching somebody work. So he was injured 7 years ago on a motorcycle. Nice guy, treated non-operatively. Again, saw 2 surgeons or something like that. They wanted his injuries to heal, see how he did. And he's not doing well. He's become brace dependent. He's got progressively worsening symptoms, feeling like the knee is collapsing inward, and he reports 3 times that his patella dislocated laterally. On examination, he's got an MCL, PCL, a little bit of posteromedial corner. He's got patella apprehension, but the tracking is good, and he walks with a valgus thrust. His numbers are here. Not a terrible deformity. So maybe a mechanical axis deviation of 12 or 15 millimeters. And if you equate that into the mechanical tibial femoral angle, it's around 4 degrees, which if you put that back to the biomechanical data I showed you, it's really kind of on the borderline for the superficial MCL middle bundle. So thinking about what to do for him, it's amazing he's got no OA after a KD2 chronic with a patella dislocation or patella instability. His PCL looks pretty okay. Slope is normal; it's 8 degrees. Here's some key MRI slices. Sorry, PCL is gone. It's completely absent, which is consistent with you can see in the bottom left, consistent with that history of his injury on his motorcycle happened 7 years ago. His MCL is largely deficient as well, very atrophic proximally. His patella sits nicely in the groove, even on a supine MRI, which is a good sign. And he has some deficiency, sort of the medial structures, but they're there, so you can follow them through. His ACL is hanging on a little bit. It's obviously getting stretched by his chronic valgus, which is, a thing that we all would know about and understand about. So lots of things to think about for him. The ligaments, it's a primarily PCL, MCL situation, chronic with some dynamic patellar instability. I think he's probably getting patellar dislocations because if he collapses inwards, he kind of goes into more significant valgus. Should we address the patella? Should we do an MPFL? His slope is pretty good for his PCL. Do we need to change it? Probably not. He says he's not smoking, but he might restart. And doesn't have a significant bony deformity, sort of on the higher end of valgus on the tibia and a normal femur. And so for this case, I said, well, the problem is on the tibia. Let's do a closing wedge. Probably overcorrected him a little bit, but still made his mechanical access pretty much in the tibial spines or just on the medial spine. And then I put a POL and MCL reconstruction with an Achilles allograft split underneath the plate, which is the first time I've done that. So you can see the graft is in the femoral tunnel with the bios screw and backup fixation over here, which you can't see. And then we left the central portion. The graft is sort of in the middle. I left the plate off the bone so as not to squeeze the graft down too much. And we put the graft in between the central screw of the T plate and then did sort of standard fixation down here through it. And so far, this was 3 months ago. So far, it seems to be holding. He's still not smoking. I kept him protected for about 8 weeks for the MCL portion, not as much for the osteotomy portion. Back to the lateral side, we'll talk about a subacute case. This is, I don't think you can have a complex knee instability talk without a high BMI, low velocity patient. So here it is. Lovely lady. She's 40. She works with kids in a preschool, so not super high demand. Her BMI is over 35, but otherwise undisclosed. And she is a type 2 diabetic, recently placed on insulin, but her A1C is pretty good. She had a low velocity injury, a simple slip and fall 10 weeks before you see her. And she can stand right now and she can walk, but she couldn't do a PA flexion weight bearing view, so she couldn't stand in a flex position. A little bit of a difficult exam because she's definitely subacute. So she's around this 2 to 3 month zone, almost meeting my criteria where, she's chronic because she can walk and she can do a 3 foot. Her PCL is injured on examination. Her MCL feels good. She opens a little bit on the lateral side in extension. I wanted to dial her, but she really couldn't. She's still having pain. And then you can see on her images, she's got this sort of pending non-union of her fibular head fracture. She's got a pretty flat slope, so a 2-degree slope on the lateral. Um, and this is her standing alignment. She's just a little bit varus. So there's a lot of things to think about for her. Here's her imaging. Her injury mechanism makes immediate sense when you see her CT. So that's this upper right corner here. You can see that she's had a hyperextension mechanism of injury. That's the anteromedial plateau. So it's a hyperextension varus, and that obviously pulled off the posterolateral structures, and it resulted in this fracture. I very rarely fix the femur. So if you're a shoulder surgeon or I like the shoulder in theory, just not operating on it. This is almost like a Hill Sachs, and this is like a bank cart for your ball and socket. And so it's hard to get this to engage. But this can sometimes be problematic, especially if the tibia is sagging and there's a significant anterior medial fracture. I will fix those. But hers was relatively small, just a chip in the bit of the capsule. But it definitely gives you a clue of what happened to her knee when she slipped and fell. Her ACL is intact, her PCL is torn, and then you can see here that her fibular sort of head with the LCL has this sleeve, almost like a capsular sleeve with communication into the joint. There's fluid in the cleft that goes all the way into the joint. So she's had a peel off of her posterolateral capsular attachments and her LCL with this fibular head. What are we going to do for her? Well, I thought she was lower demand, and I thought doing big ligament reconstruction might just be my backup in this setting. I thought about non-op, but the problem is she's 10 weeks out, no sign of healing on that fibular head, opens a little bit in extension. She's got a flat slope, which is going to mean her PCL is a problem. And so what I thought here to do was to basically get her to a PCL deficient state with a relatively normal lateral side. It's still within the realm that we could fix it. She could probably handle being PCL deficient if she had a normal slope. So that's what we did. We did a slope increasing, slight valgus producing osteotomy to detension that side. I did a repair of the capsule with an anchor and fibular head ORIF after sort of doing standard kind of drilling out the pending non-union. Last case, and then we'll take questions. This is an interesting one as well. Somebody comes in PCL and posterolateral structure deficient, but has no history of trauma. And so there's only one situation that I see clinically where that happens, unless it's congenital, and it's with these jiu-jitsu people, which is like a red flag. So unlike case number 3, this guy is in shape. He's fit, healthy, works out. He's a massage therapist. And he's had this issue with his right knee where in the last maybe 5 years, it's become progressively worse for him. He has medial knee pain and he feels a sensation of instability in his knee that he has difficulty describing. He does grappling basically daily, and if you are a grappler or you've watched any videos of this, the jiu-jitsu folks like to use their lower body as levers, either whether you're receiving the hold or doling out the hold. So it's like a double-edged sword, and you'll see all kinds of sort of repetitive trauma deficiencies in these patients because their knee is getting torqued in a non sort of traditional hinge fashion. So his exam, he's got a low-grade PCL, a very high-grade posterolateral corner, and he's got uh, varus on his imaging. He's got Kellgren-Lawrence, maybe grade 2 to 3 changes. Starting some medial joint space narrowing with sclerosis here on his PA flexion view. A very interesting lateral. So like his slope is pretty reasonable. But if you look at his lateral, our technologists managed to get a perfect lateral of the femur, which is a miracle in and of itself. But then if you look at his tibia, for me, this is way too much fibula showing, and it suggests that the tibia is a bit externally rotated. He's got a significant mechanical axis deviation. He has an interesting examination. I was teaching the resident. I don't know how to turn the sound off so you can hear my weird narration, but we'll get there 1 second. Here's his ACL intact. Here's his PCL, maybe stretched, but I would also offer that this could be a weird MRI slice. You see the femoral insertion of the PCL and the tibial insertion, and you shouldn't because they should be out of plane. The tibia insertion of the PCL is quite a bit lateral in the sulcus, and then obviously it inserts onto the medial wall. And so it happens here if you have external rotation, they'll become in profile. And so it offered that this is actually more of a sign that he's got this external rotation problem. Here's his LCL stretched out but intact. Here's his popliteus also stretched but intact. Here's his examination. I'll try to turn on, I could turn off the sound, I guess. Yeah, I may do that. There you go. Showing our resident his strange examination. So obviously significant posterolateral component. He's got a posterolateral drawer, but his medial side didn't have a significant dial, or sorry, a significant posterior drawer. So if you have no significant step off, that's my thumb on the medial side. You can see that you might think that he's got a significant PCL injury here because it looks like he's sagged, but all the sagging is from the lateral side, and it's because the lateral side goes back and externally rotates when you do that. And if you put your thumb on the medial side, you'll actually notice he has very low grade step off there or negative thumb sign on the medial side if you hold him in neutral rotation and do a posterior drawer. So an interesting physical exam worth looking at. My impression of the Brazilian Jiu-Jitsu folks is supported a little bit in the literature. This was an interesting MRI study in Brazil. They looked at somewhere around 2,000 MRIs and they found, I think it was roughly 25 cases of isolated posterolateral deficiency, and more than half or about half of the patients were referred for jiu-jitsu associated injuries or complaints. And then everything else, there was a bit of soccer, and then everything else was one-offs like motor vehicle and whatnot. And then here's a list of what they thought went with the PLC. So capsular ligamentous structures in a high proportion, LCL, at least partial injuries in a high proportion, everything on the lateral side essentially showing up with that chronic PLC. So for this guy, I opted to address his medial OA. Remember, we talked about the importance of getting those PA flexion views and assessing pain, etc. as a symptom. I tried to be relatively neutral on his slope, and we tried to give him a more neutral standing alignment and compress the lateral side. So we did sort of like that LaPrade study, 10 millimeters at least. I can't remember what his physical examination shows like. I would come back and do posterolateral structural reconstruction on this patient, but I will only do that if they stop grappling, and I will leave that as a tip for you. If the patient's going to go back to the activity that was associated with this problem in the first place, then probably not a good time yet to do that soft tissue reconstruction. So final pearls. A true high-grade insufficiency of the collateral almost never occurs in isolation. You got to watch for the cruciate and the corner injuries. They're there at least partially in the majority of the cases. When you see your patients and they have a collateral laxity problem that's chronic and symptomatic, it also usually occurs with malalignment. And I always think about, seeing these acute MCLs and stuff like that in our acute knee injury clinic. If they look like they're in a lot of valgus, I might even put them on touch weight bearing for a while or an unloading brace. And it goes back to sort of that biomechanical study where if you're in enough valgus, that MCL probably not going to heal very well, whereas the majority of patients with a normal alignment or varus for sure will heal fine. Stress views are helpful. I didn't talk about any in these cases, but I pretty much primarily use them in the patients that have a high BMI with high laxity in their knee. And so you feel their other knee and there's play in their other knee, but that's their normal knee. And so it can be really hard to grade your physical exam in that setting. And although you can still use MRI and look for structures torn, I usually would go and then get a comparison stress fused normal abnormal in that setting. That's sort of the one setting where I almost always do it. And the rest of them at this stage of career, I'm pretty confident with MRI in my clinical exam and EUA, sometimes a diagnostic scope. If you're really unsure what's going on here, that can also be useful. I would rather do an osteotomy first. I think you need to use your sort of spidey sense and look at this patient. And if you think that they have a high failure rate risk, and again, it's usually that lateral side in varus, I'd rather do an osteotomy. If they're low demand, that might be their only treatment. If they're higher demand, it's going to increase their outcomes, is going to be better. It's going to increase their graft success rate when you do the second stage. And if you guess and you guess wrong, then you have to do three surgeries. So yeah, you did your primary recon, it failed. Now you've got to do tunnel grafting, osteotomy, revision. And so instead of an 18-month or 2-year process, it's now a 3-year process, and a patient doesn't play any sports after that because they're basically done. And really, at the end of the day, get your toolbox full of everything. Know your reconstruction techniques, know your osteotomy techniques, because the art of all of this is really matching individual patient needs to the tools that you have. And that's it.
Dave, thank you so much for this amazing talk. Um, we have a question here, and it's again Dr. Ahmed Alim. He said in the last case, would you do a medial open wedge with a simultaneous or a single setting fibular based like Arciera technique reconstruction for posterolateral corner slash LCL?
Yeah, I think that's an option. Again, but only if the patient is not going to go back to grappling. And he wasn't prepared to do that, so it made the decision making, really easy. There's two camps here. Like a lot of people think, set the bones, make sure they heal. Osteotomy is very good nowadays. It's different than it was even when I started practice. We were still using first and second generation poodoo plates, and now we've got lock plates and stuff like that. So the complications I think are less. We're better at avoiding hinge fractures by protecting hinges and things like that. I do think it's a risk to do a tibial reconstruction in that case. I know that the summary data of the sort of non-anatomic or fibular based partial anatomic versus anatomic suggests there's not a huge difference, but the recent meta-analysis, there is a lower range of failure rates with the anatomic. I think just level 5, this guy probably needs both. So I think I mentioned in the slide, I would usually like take a piece of the biceps and put it up to the lemur point and then do a tibial-based popliteus. So I would stage it personally for the most part. I think if the patient was like a little bit lower demand, you could definitely do just a fibular based thing with the osteotomy, but be careful and really make sure do your osteotomy first and be prepared to bail. Because if you got a hinge fracture, I still even wouldn't do a fibular based reconstruction because now you're going to have some micro motion at that hinge site, and that may compromise even if your tunnel's not there. Your tunnels in the fibular head, that still may compromise whatever you've done ligamentously on that side.
Okay. All right, we got the questions flowing now. So what's the best way to correct varus and slope in HTO without patient-specific cutting jig? How can you control your two planes?
Varus and slope, like we're increasing or we're decreasing?
Both ways.
Yeah, so controlling varus, I mean, again, you got to go back and kind of look at your, basic osteotomy data. So it depends where you put your hinge. So if you go anterolateral versus standard posterolateral, so posterolateral will allow you to get yourself sort of slope neutral to slope positive. And so if it's PCL deficient in varus, then do a standard posterolateral and just open it up at the front more. Usually we're always battling in medial OA, HTO. I pretty much put the laminar spreader only at the back because the tendency is for them to be equal or the back to be a little bit more closed down. And then I put the plate on. So in that setting, I just do it the opposite. We don't know the exact numbers. Where does your osteotomy start? And then how much bigger at the back versus the front. There's a few published papers that suggest, you need to have a differential depending on the geometry of the patient of at least 2 or 3 millimeters to be slope neutral, greater at the back than the front. So that's what I kind of aim for when I'm doing slope neutral. If we're trying to increase the slope, then you can obviously do the opposite. So, and if you're trying to decrease the slope, then you have to switch your strategy and do that anterolateral hinge approach that Dr. Petersen, I think, had a link for. But it's not an exact science because it's not really understood how much differential is going to change your slope by X. Whereas opposed to you can do a standard planning for a medial opening wedge osteotomy, whether you use the software or whether you draw it out by hand in the old school way, and be fairly accurate. It's a little bit less of a guess. Generally, like for anterior closing wedge, it's sort of like a degree, a millimeter, a degree and a half. And then what I found anyways is with the anterolateral hinge is it's about a degree for every 2 differential if your hinge is anterolateral.
Thank you. The next question is, would you consider a posterolateral corner reconstruction and an LAT for an ACL posterolateral corner injury in a high demand patient?
Sorry, it's a
So
ALL?
it's a patient that has, so he's an ACL posterolateral corner case. Would you do ACL recon posterolateral corner plus Limier or a lateral extra-articular tenodesis/ALL?
I mean, I do an LET or an anterolateral procedure if I'm doing a soft tissue graft for the ACL. I mean, I follow basically Al Getgood's trial. If they have high grade pivot, if they have 10 degrees of hyperextension, I try to think about things like in the ACL world as like they're that Venn diagram. They're overlapping. You have things that control rotation, and you have things that control anterior translation. A correction will significantly control anterior translation. Even your posterolateral and anteromedial bundles of your ACL, will do those things separately. In LET, there's some data that suggests maybe it controls about a millimeter or 2 millimeters of anterior translation, but really it controls rotation. So there's things that sit kind of in the different circles, or they all overlap. They're all really good at something and less good at something else. And so you got to dial this into your patient. If you have a high grade pivot and an internal rotation problem, then yeah, you can do an LET with your ACL. The posterolateral corner is completely different. That's an external rotation sag problem and sometimes a varus opening. So for me, I would make the decision to add an LET based on what the exam is like or based on what the patient is like. Do they have a high grade pivot? Do they hyperextend? Are you doing a soft tissue graft? And then the answer is yes to LET, PLC, and an ACL.
Okay. Thanks a lot. I have just one question, actually, myself. I had a couple of cases that were done by one of my colleagues of a revision ACL, where they did a single stage HTO for varus, plus ACL soft tissue graft and an LAT to improve basically stability and rotation. And these patients ended up with some extension lag and external rotator foot. Have you seen something like that in your practice? Question for you, Dave, first, and then Dr. Petersen.
Yeah, I haven't. I don't remember you asked me about this. I haven't seen it. I can't remember what I told you. Hopefully, it was good advice. Um, yeah, sometimes I wonder if that is a problem of over tightening of the LET versus an issue related to maybe it was too much surgery and they didn't have appropriate rehab or whatever. It is a lot of surgery to do, ACL, LET, osteotomy. I think we underestimate that a lot in these patients. I mean, we've talked a lot today about what I would call relatively complex surgeries, and then you go back through the systematic reviews. I put up a few of them. You know, the number one complication for all of those papers is stiffness. And so I think it's a generalized problem. It's hard to know, you know, if somebody kind of left their knee at 10 degrees when you have a big hemarthrosis, that's what you want to do. And then you've kind of violated the posterior part of the knee doing an HTO. So maybe they've got posterior capsular kind of constriction, and that's contributed to it. So those would be sort of the thoughts that were going through my head. I'm curious to see what Professor Petersen thinks.
Yes, so yeah, maybe I'm a little biased because I do most of my patient in two stages. I always perform or mostly perform first the H or always perform first the HTO, and in some cases I combine it maybe in highly active patients, but many of those patients who have an indication for an HTO have associated medial joint problems such as cartilage damage, etc., and slight varus osteoarthritis. So in these patients, I do it always in two stages, and in those cases, I haven't seen
Stiffness.
this scenario.
Even when you add lateral extra-articular tenodesis or ALL, or you don't like to do the ALL in general?
I always use a Lemaire technique, the anterolateral tenodesis. Yeah, it's just a technical issue. I do not like to determine my ALL or LET tunnel by the ACL tunnel as Bertrand Sonnery-Coté does it. Yeah, that's but the technique is also nice. The problem I think,
Professor Petersen, have you ran into knee stiffness if you do all these together, which I mentioned, the HTO with the ACL reconstruction using hamstrings and LET Lemiere? Have you run into patients having, lack of extension or external rotator foot? That's
yeah,
the
definitely.
they had.
Definitely, the more surgery you do, the more you increase the risk of knee stiffness. Yeah, that's another argument to do it in a stepwise fashion.
Right. Thank you so much. This was very insightful, Professor Petersen and Dr. Wasserstein. I think with that, we will conclude. It definitely went beyond what we expected. However, that tells you how much we enjoyed it. At least myself, this is straight in it's hardcore into my practice on daily basis. It's very good to reconnect with Dr. Wasserstein and to finally meet Professor Petersen. We have heard so much about him, and now we get to meet him in person. Fahad, I'll give you the mic to conclude. Thanks again from my end. I truly appreciate it. And we're looking forward to more participation from our audience and more collaborative work with our both professors in the future. Thank you so much.
Thank you very much. Thank you, Hamza, Dr. Wasserstein, Dr. Peterson, for joining us. It was a very interesting subject and very informative. I want to tell you, the audience, I think everybody has left already. The things, the webinar is recorded, and also we will upload it online, and it will be in our Instagram. And also there is a summary by AI mode will be sent to all email who already registered there. And thank you very much for joining us, and hopefully we'll see you in person.
Yeah, me too.
Thanks for having me.
Thanks for the invitation.
That was great.
Thank you so
Enjoyed
much.
it.
Thanks
Be
a
well,
lot.
everybody.
Hope to see you in the future. Bye.
Well, take care. Bye bye.